Hello everyone. I'm here again with another video. This time is about diabetes and its complications. It's part of the diabetes series that I've been recording for you guys. This is part 3. So if you're looking for medications or the overview of diabetes, I have other videos on that. So this video is just going to cover the complications of diabetes. So let's get started. So in diabetes, we have a chronic disease that pretty much slowly affects the body. And when I say the body, I'm talking about everything in the body, like organs, tissues, eyes, brain. And as you can see in this photo here, you can get a stroke, a heart attack, artery disease, diabetic neuropathy. You can get nephropathy, glaucoma, cataracts, ulcers. I mean, you name it. There's a bunch of things that pretty much a patient can be affected with when they have uncontrolled blood sugars. So, but the first thing that we're going to talk about is the both extremes. So low blood sugar and very high blood sugar. So low blood sugar is called hypoglycemia. That's the medical term. And pretty much it's a glucose that is less than 70. It could be caused by different things. Pretty much it could be too much insulin or too much medication. It could be because you worked out really hard and you don't have that much storage of glucose, or maybe you haven't eaten. It could be a sudden drop of glucose level or related to alcohol consumption. It's mostly common in type 1 diabetics, but it can occur in type 2 as well, especially if they're taking insulin and oral hypoglycemic agents. Typically, the onset of this is very quick. People can tell fairly quickly. And the symptoms could be a range of these symptoms that I'm about to let you know or discuss. So sweating, weakness, tremors, or nervousness. People start shaking. Sometimes they can see black spots in their vision, irritability, paleness, hunger, dizziness. You can have confusion. You can have possibly trouble speaking, sometimes tingling in the hands or feet, or even to the worst case scenario, lose consciousness, seizures, or coma. And now, again, maybe someone will have just one or two of these symptoms. Others might have others or more than two. Every individual is a little different. Now, another thing to keep in consideration is that when someone has very high glucose levels all the time and you drop them just a little bit, let me give you a scenario. Someone always ranges in the 180s to 200, and then you suddenly drop them to 100. Well, it's not less than 70, which is the quote classification of hypoglycemia, but because the body is used to being at a high state and suddenly you drop them to 100, even though it's considered normal glucose level, they can experience symptoms with low blood sugar. So keep that in mind when you are treating patients and you're talking to them. Another thing to take in consideration is that, and I mentioned this in my medication video, that whenever you have someone taking beta blockers, which are medications that slow your heart rate down, you're not going to have the typical symptoms of hypoglycemia like increased pulse, tachycardia, because the medication that you're taking, beta blocker, will decrease the heart rate. So just keep those in consideration. So now that you have someone with hypoglycemia, then what do? Well, first of all, we need to make sure or determine, are they awake? Can they follow commands? Can they do what you're telling them to do? So if they are awake, we teach the patients and their family members to first always recognize the symptoms first and be alert, educate them with these symptoms. But then immediately that you recognize that they're in a hypoglycemic state, You eat a 15 gram of simple carbohydrate. Well, what is a simple carbohydrate? 15 grams. It could be a soda, it could be a candy, hard candy, it could be maybe a tablespoon of syrup or honey, it could be orange juice. Sometimes at the pharmacy, they sell these glucose pills. So pretty much, anything that you have handy that is simple to digest sugar, that is going to go straight to the bloodstream of the patient. Then you take their glucose level in 15 minutes. So this actual rule, we call it the rule of the 15. So 15 grams of carbohydrate, test in 15 minutes. If it's not at a normal range, then you do another 15 of carbohydrates. And then, by then you're contacting the healthcare provider, or you're, going to an emergency room. If you're in the hospital, the protocol is a little bit different because we do have protocols for hypoglycemia, but I'll get into those here in just a minute. After the patient improves from, maybe less than 70, after you give them this 15 grams of simple carbohydrates, you want to follow up with a complex carbohydrate to prevent any further hypoglycemic episodes. So, for example, something like peanut butter, bread, crackers, a sandwich, something a little bit heavier, right? That it takes a little bit longer for the stomach to digest and pull out and break those glucose molecules. If the patient is unconscious or severely showing symptoms of hypoglycemia, especially in the hospital, that we have a great IV access and medications that we can give patients, we typically can give a 25 to 50 milliliters of 50% of IV dextro. And it looks like this. It's a blue box. You get it from the Pyxis or the crash cart. And pretty much you push 25 mLs of pure sugar into the vein. If you don't have an IV access, let's say in the field, like paramedics or things like that, they can give intramuscular glucagon. So that's another route. At home, if they're unconscious and they cannot follow commands, my recommendation is, or what we recommend is that you open kind of like the mucosa of the patient, and you put syrup or honey or cake frosting, basically sugar, into their mucosa, because it is easily absorbed and they could basically receive the glucose from there. So it's very important to educate a family as far as what to do, what to recognize, when are they acting funny, take their glucose level, and then if it's below X amount of number, then you might want to do this or that, and also educate them on what the appropriate foods to give the patient are. Okay, so now let's go to the other extreme. What is hyperglycemia? Well, this is when the glucose level is really high. The book talks more than 200. Now, there's different causes that this could be a result of. It could be too much food. It could be maybe you're not taking your insulin correctly, or you ran out of your medications. This happens a lot with people that have financial problems, or maybe lost their job or their insurance, or they're homeless, or maybe it's just simply you're sick, or you are taking a medication that increases your glucose level. Maybe is stress in your body. So stress equals sugar. Okay, remember that. Anytime that you're going through either emotional, physical, or mental stress, it just releases cortisol to the body, and that's just pure sugar. My surgical patients in the hospital, their glucose level increases, and it's because the stress in the body from going through a surgery. So, its transition is something that gets better, and they go back to normal, but for a short period of time, they're going to have hyperglycemia. The symptoms are all your pees, frequent urination, thirst, and hunger, blurry vision, dry skin, drowsiness, nausea. Again, patients can have one or two of these or multiple symptoms. To treat it, you hydrate, monitor their glucose, and then give them something to bring that glucose down, insulin or oral diabetic agents. Now, you have to seek medical help and continue your diabetic medications and increase that monitoring in your fluid when you have hyperglycemia, because it can lead to complications that we're going to discuss here shortly, such as diabetic ketoacidosis and HHS. So here's an easy to read kind of table comparing both of them, hypoglycemia and hyperglycemia. I really recommend you to do this at home when you're studying for the difference, so that way you can see it side by side. Same thing with the symptoms. And now let's talk about diabetic ketoacidosis. It's one of those main complications. Pretty much what diabetic ketoacidosis is a profound insulin deficiency. It is considered a medical urgency. Pretty much is usually mainly seen in type 1 diabetics because their glucose is pretty much out of control. The pancreas is not releasing the insulin, but it can be seen in type 2 as well. It's not that it can't happen in type 2, but it's mostly in type 1. The causes could be too little insulin with increased calorie intake, or maybe physical or emotional stress, or maybe they just haven't been diagnosed. They're young and they hadn't been diagnosed with diabetes, and that leads them to DKA, and then they seek medical help, and that's when they're being diagnosed with diabetes. It's usually about 40% of new diagnosed clients or underdiagnosed. The onset is gradual or sudden. So it happens pretty much kind of quickly. And the precipitating factors could be just infectious disease problems, or stress, or insulin withdrawal. Maybe you ran out of medication, as I said earlier, or underdiagnosed cases. Let's see. So let's talk about what happens in DKA. So you understand kind of like a little bit of the pathophysiology. So we have the pancreas that releases insulin, and insulin is the key for the cell to accept the glucose and kind of store it in the cell. So when that key doesn't, it's not being produced and it's not present, you have this increased glucose levels in the bloodstream. So pretty much the amount of glucose and ketones, which I'm going to talk to you here shortly about ketones, increases in the blood due to this lack of insulin in the body or in the bloodstream. Because the body is starving for glucose and energy, it breaks down fat. And the breakdown of fat is what creates these ketones that are very, very acidic. And it throws the body into basically an acidic state, elevating your pH, making it, not elevating your pH, lowering your pH, making it into a metabolic acidosis state. Now, because of the glucose content in the bloodstream, your body is basically trying to get rid of all that. We're going to call it glucose molecules, right? And so what do? Well, you start peeing and you dehydrate. The patient gets dehydrated. It loses an abundant amount of fluid through your urine because they're trying to get rid of those molecules. The acidic state causes the other symptoms of diabetic ketoacidosis, such as nausea, electrolyte imbalance, could be vomiting, some disturbance in their mentation, Um, and the body compensates by making you breathe faster because it's trying to release carbon dioxide, which is acidic too. And so you get these cool smalls breaths, which are deep and rapid to expel carbon dioxide. Sometimes when the patients are in ketoacidosis, they have this fruity kind of smell to their breath, and that's the ketones pretty much. So how does it manifest? I kind of explained to you already. You have nausea, you have some vomiting, you have some abdominal pain that comes from the acidotic state. You have this cool smells and fruity and sweet breath, like breath, yeah, breath. You have an electrolyte imbalance. You have the polyuria that shortly after it basically dehydrates a patient will turn into oliguria. So they stop peeing or it's very decreased. You have the dry mucosa, the skin, poor skin turgor. You can have hypotension from the dehydration. But the first kind of symptoms that you see or the patients recognize is this tiredness and weakness. And then the, urinating, thirsty, and hungry. Those are the first symptoms. Your labs are going to look like 250 or above. You're going to have positive acetones or ketones in the urine. You're going to have glucose in the urine. You're going to have a low pH that makes it acidosis. And then you're going to have a low bicarb, which that makes it metabolic. And all this acidosis and metabolic, it's going to make sense when we go over or when you see the acid-base imbalance video, or you sit in lecture. So how do we treat it? Well, sometimes the patients, if they can recognize it earlier, not always they are hospitalized. They can be treated outpatient, but in order to treat it outpatient, you cannot have complications. You have to be sort of stable, and you have to recognize it early. So to treat it, basically, you have to consider the level of consciousness. You want to protect the airway from the vomiting. You want to supply some oxygen, establish the hydration. So they're dehydrated. So we're going to give them some fluids. We're going to monitor their glucose level. And this is done very often, especially when they start receiving insulin IV. You can be taking glucose levels every 15 minutes, every 30 minutes. That's how often. You're going to give them regular IV insulin. This is the only insulin given IV, regular. You're going to replace their electrolytes. Whatever is off, we're going to give it to them. Clients can go from very high potassium levels to very low from the insulin. So insulin makes the client basically lose potassium. And so you might have to replace that. You want to monitor their EKG rhythm because high potassium or very high potassium can cause dysrhythmias in their heart. You want to give them sodium bicarb if their bicarbonate is low. You want to monitor their blood pressure, all their vital signs, intake and output. And because you are replacing their fluids very quickly, they are high risk of fluid overload. So you want to make sure that you're assessing their lungs, make sure that their lungs are clear, their saturation is at a reasonable level. We like it above 92, 93, etc. The administration of insulin for these patients is that initially they're going to have it IV, and then shortly after, when their glucose kind of reaches a certain level, then they start kind of bringing it down and shortly kind of titrating it. You will also change the solution of IV from regular normal saline to something with a little bit of glucose to prevent any hypoglycemic state from all the insulin that you're giving them IV. And then eventually, once they start getting to a level, an equilibrium, so to speak, then they'll transition these patients to a floor, and they supplement the IV insulin with sub-Q insulin. So these patients are mainly going to be in the ICU initially because of all the monitoring, and then they'll transition to your med-surg floor. And you're going to see them in the hospital where they were admitted with DKA, and now they're in a med-surg floor, but they went through kind of like ICU. Okay, what else I want to tell you about this? Don't forget to assess their mental state as well. I'm not sure if I mentioned that earlier. Okay, the next complication is HHS, or also hyperosmolar hyperglycemia syndrome, which is a mouthful, but we abbreviate it as HHS. This is pretty much where your body is producing a little bit of insulin, but not enough to prevent the hyperglycemic state. And this diuresis that happens when your glucose is really high, because again, the patients want to, or the body wants to release all those glucose molecules, so you start peeing. But the big difference here is that the patients don't have ketones. It's not an acidic state. Another big thing is that this is considered a medical emergency. DKAs is urgency, not emergency. It's life-threatening. As a matter of fact, the mortality rate is above 50%. And this happens mainly in elder patients with type 2 diabetes. So what happens is why is it most common in elders and type 2? Because they're producing a little bit of insulin, but then they get sick, let's say an infectious process, like they get pneumonia. Then the stress in the body, the infection increases their their glucose, increases their glucose. They're not releasing that much insulin. But because they're elders, maybe they feel bad, they're not hydrating very well, they start having those 3 Ps, they're not taking a lot of fluids, and boom, the disaster happens. So it's gradual, it's not a quick onset like DKA. Let's see, it's not as common as DKA. And as I mentioned earlier, some of the most common causes are infections or people not taking their medications, or maybe new diabetics. To prevent this condition, you kind of want to drink a lot of fluids, or want to educate your clients to drink a lot of fluids whenever they get sick. That's why I put this cup of water here, because it usually happens during an illness. So let's look at the manifestation. So you have very severe dehydration, water, water, water. Remember water, water with HHS. Severe dehydration. Skin turgor is poor, dry mucosa stirs, tachycardia, hypotension, all my Ps, tiredness, weakness, change in level of consciousness, and vision, because they're the same as hyperglycemia. You have your glucose, it's very elevated, more elevated than DKA. We're talking above 600. Then you have this serum osmolarity at 350 or higher. And osmolarity is the concentration. I kind of gave you a reminder here. We want to be in an equal concentration, but whenever there's high concentration of a solute like glucose molecules in the bloodstream, water comes in to try to flush all that, and then consequently, then you start peeing big quantities of urine. Ketones are absent, and your bicarb, it's normal. So you don't have the Kussmaul's breathing here because we're not in an acidic state. So those are big difference between DKA. Again, I really recommend you to do a table and put them side by side, comparing and contrasting the differences. And I actually have one of those in my resources. What do we do? Well, you want to protect that airway, check the level of consciousness. They can be unconscious. Hydrate, hydrate, hydrate. And when we talk about hydrating, it's not about 1 or 2 liters of fluid. We're talking about 6 to 20 liters in a period of 24 to 48 hours. So these patients are a way higher risk of fluid overload. You have to monitor those lungs. You have to monitor the in and outs to make sure that they are excreting all this fluid. Monitor the glucose level, administer insulin. They need insulin. You know, they have a little bit, but it's just not enough. And then replace the electrolytes. Make sure you watch out for their heart rhythm because of high potassium and low potassium. But pretty much here, the main things are going to be fluids and insulin. The other two sort of complication or issues that happen with diabetes is Simoji and Dawn phenomenon. Dawn phenomenon and Simoji, students get it confused. They confuse them often, but I'm going to try to break it down in the most simple way so you guys don't get it confused. So Simoji is a rebound effect. So we have too much insulin that is being administered at night. During the times of 2 in the morning to 4 in the morning, your glucose level drops to a hypoglycemic state. And then the body is so smart that says, whoa, what are you doing to me? I need to release these hormones like glucagon, growth hormone, cortisol, and epinephrine to keep me back in balance and bring me back. And so in the morning, when you go take the glucose for these patients, they're high. But the problem is that you administer too much insulin at night, and that's what caused them to drop. And then the body goes crazy and tries to help the body, right? It tries to help you. So here the problem is that you might want to, in the morning, talk to the physician so that way they can reduce the insulin amount at night. So they have to adjust it at some way or some point, they have to adjust it in order to prevent this rebound effect. How are you going to tell? Well, take a glucose level around 2 to 4 o'clock in the morning, and you're going to see that they are really low. That's how you usually, pick it up, like diagnose it in a way, okay? Now, the dawn phenomenon happens mainly in young adulthood, adolescence. And basically what happens here is that we have these 2 counter-regulatory hormones, the growth hormone that is very high in adolescence and young adulthood, and cortisol. And they're released in the early morning hours, 2 to 8 o'clock in the morning. And this causes hyperglycemia. So in the morning, when you go take your glucose level, you're going to see that pretty much they are in an increased hyperglycemic state. So here the fix is the physician has to adjust the regimen to where they're maybe giving at different times insulin or long-lasting insulin like Lantus, so that way we cover these patients during the early mornings and then you don't see it. The next thing is diabetic neuropathy. Pretty much diabetic neuropathy is you get these nerves that are damaged due to the high glucose content. This is very common. It happens, I'm going to say, almost in all patients that are diabetic. They lose sensation, they get nerve pain. That leads them to injuries that they cannot feel, and later on infections and amputations. They are high risk for burns and injuries. The treatment for this is that you want to control the glucose, so you want to prevent neuropathy. Make sure that you give them medications to control the glucose, but also there's medications for the nerve pain and protect their feet at all costs. So medications can include antidepressant, tetracycline antidepressants, also selective serotonin and neuroepinephrine reuptake inhibitors such as Cymbalta, and anti-seizures, which are anti-seizure medications, which are very common. These are the most common: gabapentin, Neurontin, or pregabalin, Lyrica. The problem with these anti-seizure medications, which are the most common ones, you're going to see them often in the hospital, is that they can cause sleepiness and drowsiness. So you have to teach the patient to be careful with while operating heavy machinery. You want to avoid that. You want to make sure if you're starting the dose and that new medication that they careful with things, because they could be, sleepy and whatnot. And it takes time to work. They don't work immediately. It takes weeks, 2 to 3 weeks.
Other complications are neopathy, retinopathy, and nephropathy. Pretty much, I'll let you read about these in the book, but neopathy is about the vessels. Retinopathy is the leading cause of blindness, and nephropathy is what leads to end-stage renal failure. The vessels in the kidneys get damaged, and that leads to the kidneys not working correctly. Another complication could be cardiovascular issues like a heart attack and stroke. Same thing, it has to do with the vessels. And then peripheral vascular disease, ulcerations that get infected and lead to amputations. I hope this was helpful, and I will see you in the next video. Bye-bye.